Experience it here. Step into a world of inspiration at the 2024 ASCO Annual Meeting, where the thrill of scientific discovery and the power of global connections converge. Join us in Chicago, May 31st through June 4th. Register now at am.asco.org.
Hello and welcome to the ASCO Daily News Podcast. I'm Dr. Neeraj Agarwal, the director of the Genitourinary Oncology Program and professor of medicine at the Huntsman Cancer Institute at the University of Utah, and editor-in-chief of the ASCO Daily News. Today, we'll be discussing practice-changing abstracts and other key advances in GU oncology featured at the 2024 ASCO Genitourinary Cancers Symposium. Joining me for this discussion is Dr. Todd Morgan, the chair of this year's ASCO GU. Dr. Morgan is a urologic surgeon, chief of urologic oncology at Michigan Medicine, and a professor of urology at the University of Michigan. Our full disclosures are available in the transcript of this episode, and the disclosures of all guests on the podcast can be found at asco.org/DNPod. Todd, thank you for joining us today.
Hey, thanks so much, Neeraj. It's an honor to be here, and I'm just thrilled to be able to do this with you.
Thank you. So the GU meeting showcased significant advancements across the spectrum of GU malignancies. Can you tell us about the hot topics that captured the headlines this year? What did you find exciting this year at the ASCO GU Symposium?
The theme of this year's meeting was 20 years of advancing science and transforming patient care. And this reflected ASCO GU's incredible milestone in GU cancer research over the last 2 decades. We were thrilled to welcome over 5,200 attendees from over 70 countries. And believe it or not, there were more than 875 abstract submissions, compared to more than 300 in the meeting's first year. Most of the participants were present in person, and that was fantastic. And it enabled great networking opportunities for experts, trainees, and mentees to exchange knowledge and ideas. And, just without a doubt, ASCO GU remains the annual meeting in our field. And it's amazing to hear the breadth and depth of the state-of-the-art science that's presented at this meeting. And really, so much of it impacts patient care the second that you return home. Additionally, the meetings focus on diversity and interactivity, networking, multidisciplinary collaboration, and evidence-based care. All were just absolutely phenomenal from my standpoint. We had a lunch session for women's networking that was a huge success. The first time we've done that. The keynote lecture by Dr. Cheryl Lee that really talked about ensuring adequate representation in clinical trials. And that was a huge hit. We had tremendous positive feedback from that lecture. There were also multiple featured sessions on different diagnostic and therapeutic challenges in localized, recurrent, and advanced GU cancers. And, Neeraj, my personal highlight of the symposium is always the trainee and early career networking luncheon on the first day, and then the additional networking luncheons on the 2 following days. I had great conversations with a ton of trainees and junior faculty, and I feel so fortunate for the opportunity to get to know the future superstars in our fields. So, I just want to kick it back to you for a sec, because the first day started with a focus on prostate cancer and some of the key clinical trials. And a great example is Abstract 17, which was the second oral presentation delivered. And really, congratulations to you, Neeraj, on sharing the exciting data on the CONTACT-2 trial, which we were eagerly awaiting. And I'd love to get your thoughts on the data that you presented. Could you tell us more about that trial?
Yes, Todd, I agree with you. Such an exciting conference overall. And thank you for your leadership of this conference. So let's talk about the CONTACT-2 trial. It was a phase 3 randomized trial assessing the combination of cabozantinib and atezolizumab versus a second NHT in patients with metastatic castration-resistant prostate cancer after progression on one NHT. So this patient population had to have extrapelvic soft tissue metastasis, which could be liver metastasis, lung metastasis, or lymph nodal metastasis. And about up to a quarter of patients had liver metastasis. And overall, this is a high-risk patient population, which got randomized to, as I said, cabozantinib plus atezolizumab versus second NHT. And these patients had received a prior NHT and mostly in MCRPC setting. The or dual primary endpoints for overall survival and PFS, progression-free survival. And unique thing was with this PFS was this was assessed only by RECIST 1.1, because per our discussion with the regulatory authorities, trial was focused on soft tissue metastasis because of questions in the past that cabo can affect the bone lesions in a artifactual fashion, possibly concerns. And that's why the PCWG3 was not used in the primary endpoint, but it was indeed used as another key endpoint. So we have information on both. Anyway, coming back to the endpoint, randomization, 1-to-1 randomization. The randomization was stratified by presence or absence of liver metastasis, prior docetaxel chemotherapy, and the setting in which NHT was given, so MCSPC or CRPC setting. The PFS or primary endpoint was significantly improved with a 35% reduction in risk of progression or death with cabo-atezo versus second NHT. And there were trend for overall survival with a hazard ratio of 0.79 favoring the cabo-atezo combination. Interestingly, all subgroups were benefiting regardless of age, region, site of metastasis. But we decided to choose 3 clinical subgroups of interest, such as patients with liver metastasis, patients with the prior docetaxel chemotherapy in the castration-sensitive setting, and the bone metastasis. And all these subgroups seem to be benefiting with the strongest signal in the liver metastasis subgroup with a 57% reduction in risk of progression or death, which I would argue we have never seen with any combination or any regimen in metastatic prostate cancer setting yet, barring some targeted therapies in very selected patients. But overall, across the patient, non-biomarker selected patients, we have never seen this kind of signal. Toxicity, no discussion is complete without toxicity. So I'd like to highlight that. Safety signal, there were no new safety signals. The most common grade 3-4 adverse events were hypertension in 7%, anemia in 6%, which was similar in both arms. And of course, diarrhea and fatigue in 4% each. And if you look at secondary endpoints, time to chemotherapy, time to symptomatic skeletal event, they tend to favor cabo-atezo. To sum it up, cabo-atezo showed significant PFS benefit with a 35% reduction in risk of progression or death, with a trend for overall survival in this patient population with unmet need. So thank you so much, Todd, for allowing me to summarize the results of this trial.
Yeah, wow. That's, so impressive and not surprising that you could so fluidly just go right through all that data. It's amazing. But, we heard some discussion of the NHT control arm in this trial. And could you discuss that for a bit? Because it obviously has implications on the similar control arm of other ongoing trials in this setting.
Absolutely. Pretty much all trials, every trial which have recently been reported or started in the metastatic castrate-resistant prostate cancer have the similar second NHT arm. Whether there were multiple immunotherapy trials, which we just reported, or new trials which are starting or just started enrolling patients. And the reason for that is no randomized trial has ever shown superiority of docetaxel chemotherapy over a second NHT after failure of prior NHT in the MCRPC setting. That's number one. If you look at the NHT as a control, it is accepted by health authorities globally with multiple, as I said, recent trials which are just starting also having NHT arm. And it would not have been possible without the approval of global regulatory authorities across the world. Then if you look at the recently reported trial in the MCRPC setting with prior treatment with an NHT, there is an indication that chemotherapy may not be superior to NHT. For example, in the Keynote 641 trial in patients with MCRPC with prior NHT, randomizing patients to enzalutamide plus pembrolizumab versus enzalutamide, the median PFS with enzalutamide was 9 months. And it is very similar to with docetaxel. So patients randomized to docetaxel plus pembrolizumab versus docetaxel, the median PFS with docetaxel is 8 months or 8.3 months. And then lastly, if you really want to have a comparison of a chemotherapy with NHT, which has been done after progression on NHT and docetaxel chemotherapy, so later line of MCRPC setting, and that is CART trial, as you can imagine, cabazitaxel versus NHT, especially in patients with visceral metastasis, which was the point of discussion, like people may not feel comfortable randomizing patients to NHT compared to taxane. the hazard ratio for PFS supporting cabazitaxel was 0.79. So almost 0.80 PFS hazard ratio, which we have never seen turning out to be in clinically significant benefit. So if you combine all these data together, I think it was absolutely acceptable to us as investigators to have a NHT, second NHT as the control arm. And of course, when we are consenting the patient, we have to keep alternatives in mind. And we do talk about those alternatives with the patients. And if alternatives seem more applicable, we should not be talking to patients about those clinical trials or a given clinical trial in the clinic. I'm glad you brought this up, Todd, because this control NHT arm is not an issue with this trial, or I'll say not a topic of discussion, but all trials which should be presented in ASCO, GU in the future meetings in coming years. So thank you.
Yeah, thank you. It's such an important topic and an important, it's a controversy at some level, but it's a difficult problem to think about and obviously highly relevant to all the trials that we're looking at. Congrats again for that trial. That's tremendous. There was another important randomized phase 3 trial and it covered radiotherapy in patients with high-risk localized prostate cancer. Can you give us your insights on that one?
Yeah, Todd, I think you're referring to late-breaking abstract 259 titled Long-Term Results of Dose Escalation of Radiation Therapy from 70 gray to 80 gray combined with long-term androgen deprivation therapy in high-risk prostate cancer, GTUG AFU 18 randomized trial. And as you mentioned, Todd, in this randomized phase 3 trial, Dr. Christophe Hennequin and colleagues randomized patients with high-risk prostate cancer, which means they had to have either clinical stage T3 or T4 disease or PSA equal to or greater than 20 nanogram per mil or Gleason score between 8 and 10. So these patients were randomized to receive ADT for 3 years combined with either dose-escalated, intensity-modulated radiotherapy. So I'd like to highlight this was in the context of IMRT in the dose of 80 gray or a conventional dose of 70 gray. And now you can argue more people are using more than 70 gray nowadays, but across the world, conventional dose is still considered 70 gray. So 80 gray versus 70 gray were tested. Patients also have to have negative lymph node status on CT scans and MRI. And the primary endpoint was biochemical progression-free survival or clinical progression-free survival at 5 years following the Astro-Phoenix definition. Secondary endpoints, and these are quite important secondary endpoints, including overall survival, acute and late toxicity, and quality of life. The best part is trial met this primary endpoint with a 44% reduction in risk of biochemical or clinical progression or death in the dose escalation radiotherapy arm compared with the conventional radiotherapy arm. Interestingly, a significant 52% improvement in prostate cancer specific survival and a 39% improvement in overall survival was observed in the dose escalated arm. So 80 gray continued to be superior to 70 gray IMRT across the primary and secondary endpoints. Now, best part is regarding the toxicity profile, there was no significant difference between the two arms, with 78% patients in the higher dose arm and 76% patients in the conventional arm experiencing grade 2 or more toxicities.
Great summary and really important. Great news for our patients. Of course, a slightly different setting as it's high-risk localized prostate cancer. I checked in with our radiation oncologist at University of Michigan after that, and because I couldn't remember exactly where we are in terms of dose on these patients. And they were like, yeah, we've been doing 80 to 90 gray for several years. So it's great clearly having this data to support that. And I think, as you said, the field at many centers has already moved that way. And again, the key takeaway from this abstract would be that IMRT in combination with long-term androgen deprivation therapy is effective and safe and increases not only the biochemical or clinical PFS rate, but also the cancer-specific survival and overall survival, again, in high-risk localized prostate cancer patients. And it does not appear to increase long-term toxicity. So really important.
Yeah.
It'd be great to switch gears now to kidney cancer, if that's okay, and talk about some key abstracts in that field. What do you think?
There were so many exciting data in all cancers, which is amazing. So, Todd, let us discuss, if you could tell us about the late-breaking abstract 359, which I thought was one of the most impactful abstract presentations in the ASCO GU this year, titled Overall Survival Results from the Phase 3 Keynote 564 study of adjuvant pembrolizumab versus placebo for treatment of clear cell renal cell carcinoma.
Yeah, this was a really big moment in our field, complete with a mid-presentation round of applause that was well-deserved. And so this abstract was presented by Dr. Tony Choueiri from Dana-Farber Cancer Institute, and it included patients with clear cell renal cell carcinoma at intermediate high or high risk recurrence, meaning that they had positive nodal disease or negative nodal disease with PT2 and grade 4, or sarcomatoid features, or stage PT3 or 4. And these patients underwent nephrectomy with or without metastectomy less than 12 weeks before randomization and had not received prior systemic therapy for clear cell RCC. Patients were randomized to receive either pembrolizumab 200 milligrams or placebo IV every 3 weeks for at least 17 cycles or until disease recurrence, intolerable toxicity, or withdrawal of consent. And disease-free survival by investigator assessment was the primary endpoint, and overall survival was a key secondary endpoint. And in this abstract, Dr. Choueiri and colleagues report results of the third pre-specified interim analysis with a median follow-up of around 57 months in 496 patients receiving pembro and 498 patients receiving placebo. So just as a reminder to the audience here, the first interim analysis reported at a median follow-up of 24 months and showed a significant reduction of 32% in the risk of recurrence or death in patients in the pembrolizumab. And then subsequently, in November of 2021, the FDA approved pembrolizumab for the adjuvant treatment of patients with RCC who are at intermediate high or high risk of recurrence following nephrectomy or following nephrectomy and resection of metastatic lesions. At that time, though, overall survival data were still immature. So at the third pre-specified interim analysis with a median follow-up of around 57 months, pembrolizumab showed for the first time in an adjuvant RCC setting improved overall survival with a 38% reduction in the risk of death. And the estimated OS rate at 48 months was 91.2% with pembrolizumab and 86% with placebo. Furthermore, the OS benefit was observed across key subgroups, including patients with non-metastatic disease, patients with metastatic but no evidence of disease, patients with PD-L1 combined positive score less than or greater or equal to 1, and patients with presence or absence of sarcomatoid features. So each of these subgroups, this kind of looking down that forest plot, looks really impressive. And the DFS benefit was similar to previously reported interim analyses with a hazard ratio of 0.72. Also, no new safety signals with pembrolizumab were observed. So just tremendous data.
Thank you, Todd, for such a great summary of these very important results. So the key message from this abstract, as you said, is that after median follow-up of around 57 months, this is a long follow-up, adjuvant pembrolizumab demonstrates a statistically significant and a clinically meaningful improvement in overall survival versus placebo in patients with RCC at a high risk of disease recurrence after surgery. And this is, by the way, the first phase 3 study to show improved overall survival with any adjuvant therapy trial, any adjuvant therapy in RCC. But basically, these means we should continue to use adjuvant pembrolizumab or at least bring it up in our discussion with our patients who are in similar situation with high-risk RCC after surgery. So this is great news overall. So Todd, there was another kidney cancer abstract, late-breaking abstract 360, which compared, interestingly, subcutaneous nivolumab with intravenous nivolumab in patients with metastatic renal cell carcinoma. Could you please give us your insight about this abstract?
Sure. Yeah. Really interesting study, really interesting data that were presented. And so as you mentioned, Checkmate 67T was a multi-center randomized open label phase 3 study led by Dr. Sabi George and colleagues that evaluated pharmacokinetics and objective response rate non-inferiority of subcutaneous nivolumab versus IV nivolumab in patients with locally advanced or metastatic clear cell RCC. So patients with measurable disease that progressed during or after 1 to 2 prior systemic regimens and who did not receive a prior immuno-oncology treatment were randomized 1-to-1 to receive either subcutaneous nivolumab 1,200 milligrams every 4 weeks or IV nivolumab 3 milligrams per kilogram every 2 weeks until disease progression, unacceptable toxicity, withdrawal of consent, completion of 2 years treatment, or death. The co-primary pharmacokinetics endpoints for non-inferiority testing were time average serum concentration over the first 28 days and minimum serum concentration at steady state determined by a population pharmacokinetics analysis. A key secondary endpoint was objective response rate by independent review. So in 248 patients receiving subcutaneous nivolumab and 247 patients receiving IV nivolumab, non-inferiority for the co-primary pharmacokinetics and key powered secondary objective response rate endpoints were met. The relative risk ratio for objective response rate was 1.33. The median PFS by independent review was 7.23 months in the subcutaneous group and 5.65 months in the IV group. Treatment-related serious adverse events occurred in 6.5% of patients in each group, and study drug toxicity led to 3 deaths in the subcutaneous group and 1 death in the IV group. These results could support using subcutaneous nivolumab as a new option to improve healthcare efficiency, especially since the average injection time with subcutaneous nivolumab was less than 5 minutes compared to, I think we all know what issues are going on in infusion beds across the country, including, I'm sure, your center and mine.
Yes, absolutely. I think this is great news for our patients, Todd. Thank you. This shows that we are not only improving therapeutic options and diagnostic tools, but maybe we're also on the right track towards more practical administration routes, assisting in addressing the treatment burden and improving the efficiencies of healthcare systems. So we love to have this option available for our patients, especially who are pressured for time. So Todd, would you like to move on to bladder cancer now?
Yeah, Neeraj, that would be fantastic. I'm sure listeners would love to hear more about late-breaking abstract 530, LBA 530. Could you tell us more about this one, Neeraj?
Of course. I think this abstract is titled Enfortumab vedotin in combination with pembrolizumab versus chemotherapy in previously untreated locally advanced or metastatic urothelial carcinoma. Subgroup analysis results from EV302, which was a global phase 3 study. And it was presented by Dr. Mikhail van der Heijzen. So as our audience may recall, the EV302 trial was presented at the ESMO 2023 meeting by Dr. Tom Pauls, and results were very exciting, where for the first time a combination outperformed traditional gemcitabine cisplatin chemotherapy. In this trial, patients with previously untreated metastatic advanced urothelial carcinoma were randomized 1-to-1 to receive 3-week cycle of combination of enfortumab vedotin, which, as we know, is an antibody-drug conjugate targeting Nectin-4 expressed on the cancer cells, and pembrolizumab, which is a PD-1 inhibitor, versus gemcitabine and cisplatin or carboplatin, which were until recently standard of care in this setting and continue to be so in many countries in the world. The combination of enfortumab and pembrolizumab reduced the risk of progression or death by 55% and reduced the risk of death by 53% in the overall population. So consistent decrease in the hazard ratios for PFS and OS and consistent improvement in overall survival and PFS in that previously reported presentation in ESMO 2023. Now, based on these results, this combination was recently approved by the FDA in December 2023 for patients with these advanced or metastatic urothelial carcinoma. So now the abstract, which was presented at the ASCO GU24 meeting, reported the results of pre-specified subgroup analysis. Select secondary endpoints included objective responses, duration of response, and safety in 442 patients receiving the combination of enfortumab vedotin plus pembrolizumab, and similar number of patients receiving chemotherapy. Both PFS and OS were higher for the combination of EV and pembro among pre-specified subgroups such as race, platinum eligibility, PD-L1 expression, metastatic site, involvement of liver, or kidney function. Interestingly, the combination of EV and pembro reduced the risk of death by 53% in patients with visceral metastasis and 54% patients with node-only metastasis. So the improvement in PFS seems to be consistent regardless of the site of metastasis. In patients with moderate to severe renal function, the risk of death was reduced by 50% in patients who were receiving combination therapy. And this is one of the best parts of these results because we always felt challenged in patients who had suboptimal kidney function and we could not use cisplatin. So overall, EV plus Pembro continues to show superior efficacy compared to platinum-based regimen across the subgroups, across the site of metastasis, regardless of kidney function, and so on.
Yeah, just amazing data. I love hearing you spell it out like that. So thanks again for just the opportunity for me to sit here with you and listen to you talk about these data. And it's just impressive that we've been able to extend our therapeutic arsenal in urothelial carcinoma with an immune targeting regimen that can spare our patients the potential side effects of chemotherapy. I mean, what would your final takeaway on this abstract be?
I agree with you, Todd. I would add that OS benefit was consistently observed across these select pre-specified subgroups, including those which are historically associated with poor prognosis. So the result of this new analysis support the finding of primary results, which indicate that EV plus Pembro is a potentially new standard of care for patients with newly diagnosed, locally advanced or metastatic urothelial carcinoma. So now, before we wrap up the bladder cancer session and the podcast, Todd, could you please give us insights about LBA 531?
Yeah, absolutely. I loved getting to hear this abstract presented. And this one is titled Ambassador, known as the Ambassador trial. It aligns A031501, phase 3 randomized adjuvant study of pembrolizumab in muscle-invasive and locally advanced urothelial carcinoma versus observation. And it was presented by Dr. Andrea Apollo. It's an open-label, randomized phase 3 trial that included patients with muscle-invasive urothelial carcinoma of the bladder, upper tract, or urethra. Eligible patients had pathologic tumor stage T2 or greater and or positive pathologic nodal disease or positive margins at surgery following neoadjuvant chemotherapy, or patients with pathologic tumor stage T3 or greater and or positive pathologic nodal disease or positive margins at surgery without prior neoadjuvant chemotherapy and who were cisplatin ineligible or declined adjuvant cisplatin-based therapy. And these patients were randomized 1-to-1 to either receive pembrolizumab 200 milligrams every 3 weeks for 1 year or observation. The dual primary endpoints were disease-free survival and overall survival. Secondary objectives included evaluation of DFS and OS in PD-L1 positive and negative patients and assessing safety. So 354 patients were enrolled to receive pembrolizumab and 348 to the observation arm. 21% of the patients in the observation arm received the subsequent immune checkpoint inhibitor. At a median follow-up of 22.3 months for DFS, the median disease-free survival in the pembrolizumab arm was 29 months, while it was only 14 months in the observation arm with a hazard ratio of 0.69. At the interim analysis, OS data showed only a trend toward better outcomes in the pembrolizumab arm, which did not, however, reach statistical significance with a median of 50.9 months in the pembrolizumab arm and 55.8 months in the observation arm, with a hazard ratio of 0.98. These results could nevertheless have been impacted by the subsequent treatment of patients in the observation arm with an immune checkpoint inhibitor, especially after the FDA approval of nivolumab in 2021 for patients with muscle-invasive urothelial carcinoma based on results of the CheckMate 274. Concerning the safety profile, grade 3 or more adverse events occurred in 48.4% of patients in the pembrolizumab arm and 31.8% of patients in the observation arm.
That's great, Todd. This is such a great summary of this trial. And this is overall, I think, is exciting news for our patients with muscle-invasive urothelial carcinoma. I'm hoping that pembrolizumab will be another option for our patients when we are discussing adjuvant immunotherapy in the clinic moving forward very soon. With that, we have encountered several abstracts addressing prostate, bladder, and kidney cancer, significantly influencing our medical practices, at least at the current moment or in the near future. So, Todd, thank you for sharing your insights today. These are undoubtedly exciting updates for all members of the GU oncology community, and we are grateful for your valuable contribution to the discussion. So many thanks.
Hey, thanks, Neeraj, for having me. This was really fun. Again, it was great talking with you. I'm just really proud and excited to still be part of this field, to be part of the GU oncology field, and it continues to be exciting for all the folks who are coming up.
Indeed. And thank you to our listeners for joining us today. You will find links to the abstracts discussed today on the transcripts of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcast. Thank you very much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.